Moises, you're muted.
Everybody, I'm sorry about that. Everyone, and thank you for joining us for this important community forum, Long-Term Warriors Celebrating and Protecting Our Legacy. This forum is in recognition of the National HIV Long-Term Survivors Awareness Day. My name is Moises Agosto Rosario. I'm the Director of Treatment for NMAC, and I'm very, very happy and honored to welcome you to this virtual gathering. We come together today to honor the strength, resilience, and activism of long-term survivors of HIV. We have not only endured the physical and emotional toll of the epidemic, but we have also been at the forefront of fighting for care, for dignity and justice. And because of that, we are thriving. But we are also here because that legacy and the very important systems that we have fought for and have sustained it are under threat. Proposed federal budget cuts target the very livelessness that have made long-term survivals possible. The Ryan White HIV program, a cornerstone of HIV care in the United States, and Medicaid, which provides vital access to treatment for millions, are on the chopping block. These are not just numbers on a spreadsheet. These are programs that provide medication, keep clinics open, support case manager, and fund housing and mental health care. Cutting them risks reversing decades of hard-won progress and puts lives in danger. Our community has been here before. We know what it takes to push back. That's why today we are not just reflecting, we are organizing, and we want to re-engage with us to help prevent these cuts from passing through Congress. Before we begin with our panel discussions, I want to thank our co-sponsoring organizations and their representatives who are here with us. Aracelis Quiñones for the Latino Commission on AIDS, and Carlos Molina from Amida Care. Aracelis and Carlos, would you like to say some few words?
Thank you, Moises. Thank you, Carlos and Moises. Good afternoon, everyone, and thank you for joining us today. On behalf of the Latino Commission on AIDS, we welcome you to this important webinar focused on long-term HIV survivors. Remember that your strength, resiliency, and continued presence are a powerful reminder of the progress we have made and the work that still lies ahead. Thank you for being here. Let's continue to learn, uplift, and support each other as we move forward together.
Thank you, Aracelis. And I just want to be very brief. I want to welcome all of you. We are so excited to be here. And I want to thank the team of people that made this possible. LACOA and NMAC have been wonderful partners. So I want to thank you. I want to thank all of the panelists who so generously had offered their time, knowledge, and passion to be here with us. And of course, all of the attendees. I want to highlight 5, 6 people that really work very hard to do this. Aracelis, Moises, Bafni, Tyler, and the team from Amida Care, Shakira and Roy. Thank you so much. You work so hard to make this happen, and we appreciate it. Moises.
Thank you, Carlos. Yes. So our first, this is a community forum, and so after brief fireside chats with our panelists on this topic, we will have a robust Q&A session with your participation at the end of the sessions. Please submit your questions along the way via the chat, if you can locate it at the bottom of your screen. And so we can make sure to have them available for all the panelists. Our first session today will be on Ryan White, and it will be moderated by the amazing Judith Montenegro, who is the Program Director of Latinos in the South at the Latino Commission on AIDS. Judith?
Hi, everyone. Thanks for joining us.
If you all don't mind putting in the chat where you all are located and your names, that'll make it easier for us to see, who's joining us today and give some shout outs to some of the states doing some incredible work. I want to welcome you all as we are looking at the 35 years of the Ryan White HIV and AIDS program. And I'm joined by some amazing panelists. Stephen Vargas, who I've known for, I think, 13 or 14 years, who is a consultant and trainer and also part of the Houston Ryan White Planning Council. Joey Pons, who's a community activist and will be sharing more of his personal story, and Lindel Urbano, who is a Senior Director of Public Policy and Urban Government Relations at Amida Care. So welcome, y'all. And I want us to get started because we don't have a lot of time, and I know our panelists have a lot to share. So I want to start off by asking Stephen and Joey, and maybe Stephen, if you want to kick us off, on how has the Ryan White contributed and improved the quality and survival of people living with HIV in the US?
Joey, did you want to go first?
I can do that.
Okay.
Hello. Thanks for being here. Thanks, Stephen and Shakira. Yeah, the Ryan White Care Act was enacted, and I was one of the people that were there in Washington D.C. lobbying for this law to get approved. And it provides funding, obviously, for the treatment of HIV, and it has definitely impacted the lives of thousands of people living with HIV because it allows people with low income to access treatment and access clinical care. I have been a recipient in many ways of the Ryan White Program funds, both in New York and Boston and home now in Puerto Rico. So I was diagnosed in 1988. So it's been 30 somewhat years of living with HIV and being as healthy as I can in terms of my HIV status. Stephen.
Yeah, I can pick up from there for sure. So I think I was 28 and had been living with HIV for about a year and everything. And so I didn't know about the Ryan White program back in those days. So there was no Affordable Care Act back in those either. And not all employers in Texas even offered health insurance. So I knew that at the time that starting this treatment that was now available and saving people's lives, I would have to commit to that for life. And I just wasn't certain if I would be able to maintain that given the health insurance the way it was back in those days. So I waited until I really had to start taking medications. And I was working for an employer that had a health insurance at that point. And the wonderful thing about so it's because of those meds that I'm here today, basically, essentially. My mother had HIV, my stepfather, my uncle had HIV, and they all passed away before the advent of highly active retroviral treatment. I was diagnosed in 95, and just that very following year, 1996, was when the emergency release for folks to be able to use that as a broader public was made. And so that difference, I didn't start until my immune system began to decline. When my T cells dropped, my viral load climbed, and I noticed that a lump was starting to form right down here. That's when I started talking to the doctor about taking meds. And it was 2013. I was 45 when I started ART, and within 6 months, I was undetectable. It was that speed and the effectiveness for me that was really astonishing, essentially. It was really fast, and I was really surprised. That's the difference between how they actually, that's the difference that ART and the Ryan White program made in my life. That access to those medications when they were available. My mother died at the age of 47. I'm now 57. She died of age-related illnesses before these treatments even existed, and I've now lived 4 times longer than she did with HIV at 57. So that is that difference of survivability you're talking about that program offered me. And as far as the quality of life beyond medical care, from my perspective, the Ryan White HIV/AIDS program is unmatched in how it addresses the full scope of our needs, what we now call social determinants of health, the housing, transportation, food, childcare, mental health, substance use support, all of that stuff and more. That's why the program delivers better health outcomes than people who just solely rely on their private insurance. In Houston, if your car breaks down, you can't make your appointment, they can send a car for you to get you to your appointment and back home afterwards. You wouldn't have to worry about calling and resetting that appointment. If you didn't have money for your meds, they would make sure that you'd be able to get there and walk out with your meds if you didn't have a copay for those meds. That would not happen in a private doctor's office with your health insurance. They wouldn't send a car for you. They probably wouldn't give you your meds until you can be given that copay. What makes that work so well is that people with HIV have a seat at that table to help make those decisions to make sure we get the services that we know we need and allocate the funds into those services to make sure that we get them. Federal law mandates that those that are directly affected by HIV, that we have a say in how those funds are spent on those services and how much. It isn't just about inclusion or representation. It's more about our survival. Representation and inclusion isn't just a slogan, isn't just something passing fad. That's a matter of our survival. We have to have a say, because when people with HIV have a say, programs work better, the carrier's more responsive, and people live longer, healthier lives.
Thanks for that. And last year we heard that we received a report that a record-breaking 91% of people with HIV receiving medical care through Ryan White were virally suppressed. And so the testimonies we're hearing today about how important it is, and what's at stake for so many folks. So, Lindell, can you share a little bit about what would happen if Congress passes cuts that would impact Ryan White and what that would look like for long-term medical care and the public health consequences we would see and what some of those impacts would be in our states?
Yeah, I think the main challenge is that all the programs that support people living with HIV and AIDS work together to ensure access to care, right? So if we see cuts to programs like Medicaid, Medicare, and less access to ACA insurance, as those get affected by cut, the burden on the Ryan White program becomes heavier, because we need to remember that Ryan White is not the first line of coverage. It is the last resort when there's no other payer that can pay. And it works really well, but that's an important factor. The impact will vary from state to state. States with more resources will fare better than those that don't have as many resources. Frankly, it wouldn't be surprising to see Ryan White waiting lists reappear in states with less resources. States like Ohio, Texas, Florida, that historically have had waiting lists when federal budgets have been lean. So that's a real impact. Those cuts will be especially disruptive to states in the South and in rural America, where you see growing HIV epidemics, because they will lose vital resources. And I say that we talked about Ryan White, and I just want to put out there that I'm a former community co-chair of the New York City Ryan White Planning Council. So I want to reiterate that one of the hallmarks of the program is really people making their own decisions about how the funding gets used.
Thank you. And so, Joey and Stephen, how would these challenges affect people living with HIV who are aging?
Well, it's particularly affects the aging population with HIV, because not only do we have the challenges that everyone with HIV has, we also have the challenges that comes with aging, like comorbidities and other challenges that are beyond health, like housing, family support. We might not have any family support. Most of us don't have children, so it's extremely challenging, because as things started getting cut, and I hope that we succeed in preventing these cuts, we will be facing enormous challenges that go beyond what we already face.
Yeah, I couldn't agree more. I couldn't agree more. I put something in the chat that just a little bit on that, Lindell, that Texas, even we We don't lack in resources. You have a budget surplus for a couple of sessions in a row now. It's not that we lack the resources. We squander our resources at the cost of people's lives in Texas, essentially. And so it's not that it's so even where in states that have lots of resources that are red states, more likely won't do that investment into their programs at the loss of some of these federal funds. So my biggest concern is that 60% of people living with HIV are now over 50, in that range. And aging with HIV, it includes managing all these different comorbidities while dealing with all the instability that people experience with housing instability and access to food. The proposed elimination of the entire Hopper program, that currently serves like over 55,000 people, I believe. That is going to lead to increased homelessness for people that are aging with HIV. It's going to lead to people falling out of care with people that are aging with HIV. So that one program, because we know housing is healthcare, is going to have a devastating effect. So we need folks at the local levels to invest now. And so beyond that, I keep on thinking about the complete elimination of Part F. The research that gave me this years of difference of life that my mother experienced and that I experienced is because of that research. And so without the research right now too, in Part F, the rural dental care that we fund through that, it's a really huge concern for me about these kinds of impacts. We'll be pushing our state to redouble their efforts with investments. Sometimes it's like screaming at the wall, but they come through every once in a while. But we need to do this here at our local level, at the city level, because our city has never had funds for a line item to address HIV. Unlike some other cities that did through their own general revenue, our city has never done that and still has not. So we're pushing for them to do that just to offset some of these cuts.
And that's a great transition because I think before we end, we really want folks to have some action steps and what policy recommendations you all think that local and state and federal policy leaders should be hearing from us to ensure the sustainability of Ryan White programming and the services, especially in the federal turmoil that we're facing right now, which is, addressing all of these budget cuts. So, why don't we start with you,
Hey,
Stephen?
Judith, I'm sorry, Judith. I just want to, okay, yeah, ask a question. I'm going to throw in the last answer for that one, then I'll come in with this one. Go ahead.
To start about, what action steps and policy recommendations?
Okay, this kind of fits together too. Okay, which is the other thing that kind of hit my mind was the CDC's 340B drug pricing support, how that could actually vanish too. When I look at if you remove CDC prevention funds, a lot of clinics and folks who provide care rely on that to help qualify them for the 340B drug pricing support. And so if that's removed, how many organizations are going to be negatively impacted by that and lose out on that 340B income that they use to help other people with or without HIV who could use some kind of HIV prevention or care services? So that's another piece right now that I don't think we've really completely wrapped our minds around, but the removal of some funds jeopardize your access to other kinds of resources as well. And so I just had to say that one just on that. So we got to push on that too. But when you talk about here locally, one of the things we're going to be pushing with ceaseless public comment at city councils here in Houston is for them to create a line item in their city budget, to finally bite that bullet and do that and follow what other cities have done, and just to make up for the loss. We should have done this years ago, but if there ever was a need to do it, we certainly need to do it now. So that's one thing. And I would like them to fund some kind of housing. Think about the things that are going to be jeopardized. Fund housing since HOPA's going away. Figure out ways to offset the loss of revenue from 340B for folks that are affected from the loss of CDC funds. Those are the most immediate things that come to mind for me that we could do at the local level if we actually had a line item in our budget to address HIV concerns. And then at the state level, really, it's an uphill battle in Texas to try to establish some state HIV equity funds, period, to address any kind of racial, geographic, or even age disparities in care. So on all that front. I'll pass it on to whomever's next.
Thanks. Joey? I know you're in Puerto Rico, so the landscapes looks different, but what are some policy recommendations you would have and actions forward?
Piggybacking on what Stephen was talking about, I think it's important that communities come together and focus on lobbying local agencies and legislatures, from city councils to state legislatures, to create or to make up for the lack of federal funding to provide those services with state funding. That's really important. And in terms of lobbying, which is what we need to do, both government agencies and legislators, there's the local lobbying and there's Washington lobbying. I think that the major organizations do the Washington lobbying, and the communities, the people in their states and in the territories like me in Puerto Rico, need to reach out to their elected officials. Tip O'Neill used to say all politics is local, and they are local. We all have, well, Puerto Rico doesn't, but the states have representatives, and they have senators. So you need to go talk to them, to talk to their staffs, tell them what your needs are, what our needs are, so that they address them in Congress and in the Senate, respectively. Right now, we still have a chance to save this budget. To save a bit, or to create a better budget, by getting the Senate to not vote positively on this disastrous bill. So we still have a chance. And the last I've read, as of this morning, the number of Republicans senators is increasing that oppose the bill. So talk to your local leaders and your local politicians.
Thanks, Joey. Lindell, I'm sure that the work that you're doing with Amida Care and really working to protect the healthcare of so many patients who access services, what recommendations or action steps do you have?
Above all, we can't stay quiet, right? We can't sit back while transgender access to care is being affected, while all access to care is being affected. At Amida Care, we're working both at the federal and state level, and also at the local level, to make sure that we're doing exactly what the past two speakers said, like making sure that both people who support these programs and those that don't understand what the impacts would be. We are at the state level, we're really pushing the legislature to enact policies that are supportive of access to gender affirming care and other programs, and really protect people from being targeted maliciously in other states, by other states, while they're living in New York, simply because they're accessing care that they need. So that's just a roundup of some of the stuff that we're doing. We've been very involved. We've been trying to make sure that we're speaking in the media, mobilizing our members, mobilizing our provider network to make sure that they're speaking out, bringing together coalitions so that we're talking about this across the state, so that it's not just one voice, but every voice that could speak should be speaking. And in the interest of time, I'll stop there.
No, we have a few minutes. Like if you have a little bit more, we have some time.
Yeah, I mean, it would be reiterating more of the same. I know there were, yeah, I don't know if you had anything to add, Judith.
Yeah, so I think that as we consider Ryan White, right, and what's at stake for folks, it is dental care, right? We know that it's really hard to access dental care. And also thinking about the workforce, right? We're not just losing folks' care, like people who need care, but also the infrastructure in which we work in, where we have folks who understand the needs of people living with HIV in accessing medical care. We'll lose case managers, we'll lose folks who work in this field. So I want to give our speakers any last thoughts that you all want to share with our participants today before we turn it over to the next panel. So Stephen.
Yeah. I guess at the end of the day, the one thing I would have to say is, just as Lindell mentioned, Back to the old mantra, silence equals death. And one even more strong that can help us is the idea of nothing about us without us is for us. We have to defend the role of people with HIV in governance. My concern right now is since we are removing the ideas of racial justice and equity, that the role we currently play that's legislated by Congress could also change. And that's something I'm keeping my eyes and ears open for so we can head it off of the path because we have to defend our roles in governance and making these decisions. It's the only reason that Ryan White HIV program works so effectively. It's the only one that mandates that people with HIV have a say. And so not just the say, but the deciding factor, not just on the funds, but those services. That's why it works so well. When we no longer have a say, I may have deep concerns for our well-being. I get to my last word on that one.
Thanks, Stephen. Joey?
Well, I want to close on a very personal note. We have to take care of ourselves. We need to take care of our health and our emotional well-being. As aging people with HIV, we need to reach out to others to find support. We need to support each other. We need to have talks. We need to visit. We need to sit down and chat. We need to have a bottle of wine to talk about our frustrations because these can be times of a lot of despair. So we really need to love each other and support each other. Reach out, reach out, reach out is the most important thing to keep our mental health.
Thanks, Lindell.
Yeah, I think it's important. I want to reiterate that taking care of yourself piece. Like we know we can't take that this funding will be there, right? We can't. We're not seeing any indication that Ryan White funding is going to increase. This is a very frustrating, trying time. Take those moments to really center yourself and take a deep breath. I find that I can't watch the news. I have to read it. And when I get frustrated, I think about, did I call my legislator today? Did I make sure that I checked to see if my neighbor got to the doctor? Things like that I have to think about in the rural community where I live. So we need to take care of ourselves and keep advocating is all I would add.
Thank you. And thank you to Joey, to Lindell, to Stephen, who are really holding it down across the country in New York, in Texas, in Puerto Rico, and doing some incredible work to challenge, right, some of the narratives that are being brought on about HIV and care. We are who we are waiting for, right? We're the people we're waiting for to do this work. So thank you all.
Thank you, Judith.
Thank you, Judith. A very powerful and excellent panel. Thank you, guys. That was amazing. So for those of you who submitted questions in the chat, thank you. And we will respond to as many as we can after our next panel session. So please keep coming with the questions. We will make sure that we have time for those. Our moderator for our next panel on the impact of Medicaid, another important discussion on Medicare, is no other than Jesse Milan Jr. He is the president and CEO of AIDS United. Jesse has recently announced his retirement from AIDS United, so we're very extremely pleased and grateful to have him with us today. So Jesse, take it away.
Thank you so much, Moises, and thank you so much to NMAC for convening this important conversation for all of us long-term warriors. And this next segment on the importance of Medicaid and Medicare. As Moises said, I'm Jesse Milan, the President and CEO at AIDS United for 26 more days. And I will continue to be in this fight, not only for 26 days, but for the rest of my life, because I'm so proud to be a long-term warrior with many of these wonderful people who are on the panel that I'm about to introduce. So as we talk about Medicaid and Medicare, we've got a panel of experts. We have from NMAC, Joe Huang Recalto, who is well known to the community. Joe is the Director of Strategic Partnerships and Policy at NMAC, and he's an expert in HIV and aging. We have Melanie Reese. Melanie is Executive Director of the Older Women Embracing Life, and she's also a member of the Baltimore City and the State of Maryland Planning Councils on HIV, and she brings her great life experience as well as her public policy expertise. We have Anthony Randolph. Anthony is a community activist in New York City. He's a longtime partner with Amida Care, one of our sponsors, and we'll hear from him about his life experience with both Medicare and Medicaid. And we have the exciting Cecilia Chung, a global expert and renowned icon on transgender health and transgender human rights. She is the Director of Evaluation and Strategic Initiatives for the Transgender Law Center, and I'm proud to say she's also a member of the Board of Trustees at AIDS United. So welcome to this venerable panel. I know it will be exciting. So let's get started. Let's start with you, Joe, and you, Melanie, because you're so engaged in the policy analysis and the policy advocacy around both Medicaid and Medicare. How do you see Medicaid and Medicare, both individually and collectively, working to improve the quality of life for people aging with HIV? How do these programs really work for us? Joe, let's start with you.
Boy, Jesse, great question. Thinking about unpacking it mentally, right? But first, congratulations, Jesse, on your retirement. I know I speak on behalf of everybody at NMAC. We very much enjoy your wisdom and your way of words and your guidance. You'll be missed, but I know you're not going to go far. But I just want to personally thank you for your friendship, mentorship, and whatnot. Look at as of today, right? We're not sure where Congress is going. We know where the House went. It is a lifeline to 40% of people living with HIV. That is Medicaid. The Medicare component, and for those that don't know, I retired from the Hill after 20 plus years. And one of the things I really tried to work on, both when I was with Senator Kennedy and Barney Frank, was to get the reclassification of HIV into chronic conditions within the Older Americans Act. And we have had some success. We're not there. And I know Ron Johnson is on, and Ron has been working with me on this. He's been running the state track, and we've been running the federal track. But I think, Jesse, it's complicating in the sense that the money has to be there. I think for Medicare and Older Americans Act, with getting these funds into the states to help with costs such as transportation, et cetera, it's imperative that we get that. With Medicaid, it's a tough one given what's going on in DC and with Congress. I'm fearful that if we don't continue to act and keep the pressure on, we're going to be caught, and people will die. I mean, let's just be honest. This is how 40%, like I said, of people living with HIV, long-term survivors, sustain their antiretroviral therapies. I think the social determinants, Jesse, the Medicaid often funds wraparound services such as housing. We talked about, the 1115 waivers, targeted case management, also known as that. The impact will be, I think, great. I'll just say one more thing, and then I'll turn it back to you, Jesse. And I know I have a way of doing a word salad here, not making a lot of sense. But I think continuity of care. I think of comorbid, you know what I'm trying to say, and just chronic disease management that Medicare offers, and I think those things are essential for the health and well-being of people, especially seniors living with HIV. And we could talk about mental health and home-based care because those are all wrapped in under the Medicare system.
Thank you, Joe. And as we talk about seniors living with HIV, we're talking about both men and women. And Melanie, I know that you've been very much an advocate in this arena. We know that already over 260,000 people living with HIV are over the age of 60, and 148,000 of those are already on Medicare, and 120,000 are over age 60 heading toward 65 toward Medicare. So how do you see Medicare and Medicaid improving the quality of life of people who are aging with HIV? Melanie?
Well, I've been on Medicare for 30 years. Medicare leaves me underinsured, so I have to rely on Ryan White to cover what Medicare does not cover because I make too much income to be dual Medicaid, Medicare. So the Ryan White pays for my Medigap, it pays premiums, and it pays for my Part D prescription premiums. And hopefully Ryan White will stay in existence and be funded at its current level, which is too low as it is. But Medicare has a set price that it reimburses for services rendered, which is less than what is charged by the providers and for services that you are accessing. And if these Medicaid cuts happen, somehow Medicare is going to be impacted. I haven't read the teeny tiny printing in the 1,000-page bill, so I don't know how it's going to really impact. But I know a lot of people who are dual Medicaid, Medicare. They don't have co-pays. It covers everything, any services that they're trying to access, they get. Because what Medicare doesn't pay, Medicaid pays, and they're not reliant on the Ryan White program. Medicaid goes away or the big cuts happen, they're going to be facing co-pays, which they have never had to before. And a lot of people who do not have retirement funds, long-term care insurance policies, Medicaid is the one that covers for nursing homes, rehabilitation services, assisted living for long-term care. And when I get to that point, will rely on that for my care when I can no longer take care of myself. So there are a lot of issues that have not been addressed on how to take care of seniors living with HIV, long-term survivor. This is National Long-Term Survivor HIV Awareness Day. And this couldn't come at a more perfect time to discuss these issues that are looming large for those of us aging with HIV.
Well, thank you, Melanie. And I think we heard from the Ryan White panel that Ryan White works in collaboration with some of these other systems, and you've just given us some real expertise on how Medicaid and Medicare work in collaboration with the Ryan White program for our health and wellness. This is very exciting, but there's a unique population right now that is very much under attack, and that is the trans community. And so, Cecilia, why don't you tell us, how do you see the proposed changes that Congress and the Trump administration are proposing for Medicare? How does that, and for Medicaid for that matter, how could either of those changes impact the quality of life of people who are of trans experience? How do you see those things impacting your community?
So Thank you for asking that question, Jesse. I think that we need to go back to the history of how we get to the point that we were actually getting care using Medicare and Medicaid. It didn't happen that long ago. So it was like through advocacy of the communities and our allies in the last 20 years only, that we were able to like add gender affirming care back to Medicaid and also Medicare. And that change just happened not that long ago. And what we are seeing right now is that when they are passing this like big, beautiful bill, they didn't even like mention that they are banning gender affirming care in the languages of the bill. And so essentially a lot of people are still in the dark, not knowing what's within this budget. So we're looking at dialing back at least 20 years, if not more, like on gender affirming care and for gender transition. And as we know, like more than 40% of the trans community, especially trans people of color, are more likely to contract HIV than the general populations. We are concerned that because of that, and also because of like the kind of very hostile climate, not just to transgender people, but also to immigrants, to all peoples of colors, and to women, that we are going to see a significant decline even in HIV testing. So the actual result, I don't want to predict, but it looks really grim. And we'll find out in the next year, like when some of these data comes in to see where we stand. But I just don't have a lot of faith in what's going on right now.
Wow. And we're with you in this fight to make sure that the transgender community gets the care that it needs, especially that care that has been supported by both Medicaid and Medicare in the past. So thinking of Medicare and Medicaid, I want to talk specifically about the life experience that you have, Anthony. You have the experience of accessing both Medicare and Medicaid. Let me just say that I'm in the process of transitioning right now from private insurance through Age United to full Medicare, and I'm finding the process to be quite complicated. So tell us about your experience. What was it like getting both Medicare and Medicaid at the same time, and how have they helped you in terms of your quality of life? Anthony?
Well, I wish I could say that it was a smooth transition. I just transitioned over to Medicare in November, but I started earlier in September looking at different plans and stuff, and it was very stressful. It was very hard to actually pick a plan. When I was with Medicaid, I was more of a person. I was under a SNP program, which was Amida Care, and they knew how to deal with problems that arose being HIV positive. When I switched over to Medicare, I was a number. You were given a number and you was given a group. And when you called, they was like, what's your number? What group are you in? There was no feel of individuality there. I'll give you an example. There's a medication that when I was under Medicaid that I had, when I switched over to Medicare, they didn't cover it. So when I was prescribed it and I called Medicare, they said that's not in our formula. So I explained that this is the medication that I've had before. Can I get a waiver? Well, it's been 40 days and I still don't have an answer. I was told that since I have a prescription, I can buy it. So my out of pocket would be like $180 a month for 3 months, which is $540. Now, what if that happened 2 or 3 times a year to me? I would be in debt. There was no inter-office communication with Medicare. Um, there was nothing to alleviate the problem or conversation. There was no collaboration in Medicare.
This was just what it was. It wasn't in their formula. There was no conversation. That was it. So I find that Medicare is very stressful now. Another example is I went to the ER room. There was something wrong with my eye. I seen a doctor. I got medication and everything. And later on, I received a bill, and it said what Medicare paid, and out of what they charged, and I had to pay the rest. Now I received bills like that from Medicaid, but it always said you do not owe this bill. I was looking for that on the Medicaid care part of it, and I didn't see it. I owed that bill. So again, that's more of a burden on us. As we grow older and stuff, there's going to be things that and medications and things that we need that Medicare is not going to cover. So that's going to become an out-of-pocket expense. They don't have the innovation or the knowledge or willingness to think beyond the dollar. So people who's growing older with HIV is going to definitely be in trouble as far as things that's not covered that was covered under Medicaid.
That is a very frightening testimony for us to hear, because we know that the Trump administration and this Congress seem to be hell-bent on reducing the cost of the federal government, but doing so on the back of these important benefits that provide access to care and medications for people like us. So, Joe, we've been talking a lot about Medicaid expansion over these last few years and its important role for people living with HIV. But we also talk about Medicaid expansion as one of the things necessary to help us reach our goal of ending the HIV epidemic. Is that possible now with all these proposed changes that we are hearing Congress and the Trump administration propose for changing how Medicaid might work and who might be eligible for it?
I don't think so, Jesse. I don't want to be the bearer of bad news, but I think, to end the HIV epidemic takes all components of the EHE, right? And Medicaid obviously plays a very vital role in therapeutics, and to get people undetectable, to stop the transmission. So in short, I will say no. I want to just note one thing, and this is very important for people to understand. And some of you may know this, but if you do not enroll in Medicare, going into Medicare, around your 65th birthday, you are subject to a penalty.
Yes.
And people living with HIV that are going into that 65 years of age kind of area, you need to really pay attention, because your penalty, if you do not enroll, will go up by 10%. And that will be, I think they calculated that twice the number of years you could have had Part A. Part B, that penalty is 10% and it's for life. And I think there is a Part D penalty. I think it's 1 or 2%. So it's very important that people understand that, in addition to the financial burdens that we already face, that penalty is for life, and it comes out of your pocket. Jesse, can I just say one thing about Melanie, it's good to see you, and what a fantastic response you gave. I just wanted to touch a little bit on that dual eligible, because it's very important that we take into account the saturation that Ryan White may be under. And Moises, and we worked with Carl Bologna, Moises, myself, and Carl went and met with Senator Casey, in Pennsylvania, right pre-COVID, raving the warning flag to the Senate, and they were Senate Select Committee on Aging, saying that Ryan White, if it's not adequately funded, is going to be even more burdensome with costs because of the aging community. And that brings up the point that Melanie raised, which is the dual eligible. So if we can't get that income threshold increased, you're going to see, I fear, a saturation of Ryan White costs, because what Medicaid should be covering is not, because an individual such as Melanie and many others are making maybe $100 more a month, and they go above that income threshold. And so it's very important that as we look to navigate the chaos that we're currently dealing with. And Congress has been basically saying, well, it's Ryan White, it's Ryan White, it's Ryan White. But what they're not taking into consideration is, yes, it is Ryan White that will pick up what Medicare won't, but Ryan White is being also underfunded. And you're going to see, I fear, the cracks start to form there if they do not deal with the income threshold with Medicaid, so that people such as Melanie, who are dual eligible, and Jesse, you would be amazed as to how many millions of Americans would be classified as dual eligible that don't have a Medicare Advantage or supplement. They rely on Medicaid. And so I think that that has to be part of the conversation as we start really honing in on the Senate, urging them not to A, cut Medicaid, but B, explain that yes, Ryan White does cover, but there's a bottom to that. And we have to start addressing that bottom. Sorry, Jesse, for kind of going on here.
We have to address it, especially as we recognize that Ryan White has been flat funded for years, and that the current proposal is to reduce funding for Ryan White. So the lived experience that you've had, Anthony, of navigating Medicare and Medicaid, tell us a little bit more about the complexities of navigating the Medicare system. You've mentioned a couple of different different plans that you had to look at. Can you tell us a little bit more about that for just a second?
Well, first of all, I think all the plans know that you're becoming eligible. So you're bombarded with different plans coming at you, offering different things. Like I said, I thought I did my due diligence and I had my ducks in line when I picked the one that I wanted. And the first thing I noticed that went wrong was that my primary care doctor was no longer in that system. So now I'm stuck because I have this plan that doesn't have my primary care doctor there, a doctor that I've had for more than 12 years. So that became a issue. Of course, like I said, the medication became an issue because a lot of the plans have their own formulas that they use and go by, and the medication that you might have or need is not under that formula. So again, you're in trouble. It just seems that it's a no-win situation with Medicare sometimes. And when you try to talk with them to alleviate or find common ground and everything, it's not there. Like I said, the first thing they said with me was, "What's your number? What group are you in?" Not, "How are you? What can we do to alleviate this issue or anything?" And the first thing they come up with, "Well, you can spend out of pocket for it."
And that notification that you have an out-of-pocket cost can be very frightening because that number can be very high. So as we come to the closure of this panel and get ready for Q&A for all of us together, let me ask you panelists, for Medicare and Medicaid, are there recommendations that you would make to Congress right now that you think would be helpful to ensure that these programs help the quality of life of people living with HIV? Cecilia, let's start with you.
Why are you starting with me? So I think that the really more important part of that is to make sure we assess, the eligibility, to make sure that it actually covers, as many of the low income bracket as possible, because right now the entire system is punishing the poor. And and really, who mentioned that? I think several people mentioned it. Joe especially mentioned that, if your income goes even $1 higher than a certain threshold, your copay goes up significantly. So I think that needs to be reevaluated as well.
Thank you. Melanie, what about you?
I would say to the elected officials, your constituents use Medicaid and need it. Your constituents use Medicare and need it. Do not cut it, because it's going to cost lives in the short run, not long run, in the short run.
Thank you. Anthony, what about you?
First, I want to say that I don't think Medicare is there. I don't think they know how to deal with aging people with HIV. You know, when you become older, you have certain issues within itself, becoming older, aging. But then you have what I call the four horsemen. And for me, the four horsemen is heart disease, hypertension, cholesterol, diabetes. When you add that on to being HIV positive and aging, that's a whole different thing that I don't think they're ready for or know how to deal with. So for me, I would say to the state and federal officials, but put the funding back into research and development. Use the same urgency that you used when we had COVID, that urgency that was there to find a vaccine or something. Put money back into research and development. I asked to shore up the health insurance companies like Amida Care. They're the gold standards by which others should emulate. Make them whole so they can take care of us. They know what it takes to take care of us. Give the health centers the finance and resources to continue the hard work. They're the ones on the ground doing the hard work every day. They save lives. And then fund prevention. Education, education, education. That stops new cases and testing. These are all areas that's being cut, and these are all areas that we need to stop the spread. When they talk about stopping the spread of AIDS, this is what you need to do. You need to put money back in. You know, they're going to pay at the beginning or they're going to pay at the end. At the beginning, it's much better and it saves lives. At the end is afterwards, when we start using the emergency rooms as medical visits, as doctor visits and everything, where we can't get treatment anyplace else, so we go to the emergency room. They need to stop the cuts and refund us.
Joe, why don't we ask you for your final recommendations, or at least I know you probably have a laundry list of recommendations for Congress, but one or two that will help transition us into a Q&A for the entire session for everyone who's watching. Joe?
Yeah, Jesse, I would just say, listen, Medicaid, Medicare, they're just not health insurance programs for people living with HIV. They are, in fact, I would believe, life insurance. They are hope. They are the infrastructure in this country that turned a once fatal diagnosis into a manageable condition for millions of Americans. And I really believe like that compelling stories will ultimately win in the end.
Excellent. Well, I think we appreciate that. So now we've heard two wonderful panels, one on Ryan White and another on Medicare and Medicaid. And all three of these programs have a unique role, both individually and together, for improving the quality of life of people, particularly people aging with HIV. But now let's open up to all of you for your questions and comments. We received some comments. Thank you, Chuck, for recommending that we take our advocacy to town hall meetings in our own communities so that both our federal and local officials can hear what we think is important and why these systems are important, and even to encourage our state governments to do more, because we know there are states that are not. And we thank you, Rick, for your recommendation that people transitioning to Medicare use their SHIP counselor, their state health insurance program counselor that is funded by the federal government to help people transition to Medicare. And I can tell you, I just talked to my SHIP counselor this week for an hour and got some excellent advice. And so we thank you. So put your questions or your comments in the chat or in the Q&A, and we will move forward when getting you to talk to these experts who are both professional experts and who are experts from lived experience. But while we're looking for new questions, let me ask you, Lindell, you mentioned earlier the importance of course, Ryan White, and we're hearing about changes to the Ryan White program. What is actually being proposed that might reduce funding for Ryan White? And I understand Part F might be on the chopping block, but not everyone understands what Part F is.
Yeah, that's an important consideration. So overall, the Ryan White program in the president's proposed budget for fiscal year 2026. Overall, it's flat funded. However, a critical part of Ryan White is defunded, which is part F, which you mentioned. And part F is that part of the Ryan White that is focused on training of providers who are giving medical care and making sure that they're competent in HIV, and understanding what should be happening with people living with HIV. The other important part of part F is that's the part of Ryan White that pays for dental care. So that's really part of what's at risk. And as we all know, flat funding really is a cut because we have inflation. The program hasn't grown for many years. And with reductions in other programs, the net result is far fewer resources. So that's what's really at stake when we talk about Brian White, I say, being cut. So.
And those AIDS education training centers help, as we've heard, help providers assess all the many comorbidities and all the many medications that people aging with HIV are challenged with, and also helping to prepare people for geriatric care and for the geriatric community to take care of people living with HIV. Those providers are few and far between, but they need to be experts in our health. Are there other questions out there? I see a hand, Anthony, and then Joe. Anthony?
Yes, I heard something about Hopper going away. That's the housing part. And that's very concerning because I have an apartment through Hopper. So when you have an apartment, that gives you a stable place where you can get treatment from. So if that goes away and we have no apartments, that's very worrying. I wanted to say that Harper houses a lot of people who's HIV positive, all of them. And if that's in danger, then there's a lot of people that might be living on the streets again or living in shelters. In New York State, I know that the 340B, they actually already messed with the 340B in New York State and tried to take it away from the health centers and stuff. I guess the state thought that they could do it better. So these are things that's really going to touch people living with HIV and AIDS, especially the housing program. And that's real unsettling for lots of people that live in Hopper.
Great. Thank you for that, Anthony. Joe, we do have a comment or a question asking, what should our messaging be as advocates moving forward? Are we addressing ableism? Are we addressing ageism as we really should for how these programs might be really critical for our health and well-being for people aging with HIV? Are we really addressing it as we really should? What's the message?
Oh boy, the message is simple. Don't cut. I mean there's no reason to bake the cake any other way. But former Senator Ted Kennedy used to always tell me, one person in the office is worth $1 million on the mall. And that is that one person that goes to see that member of Congress or that state rep is worth 1 million people marching on the National Mall. And it's the one person that can often put a face to the issue, right? And so it is, we are facing very catastrophic cuts. Let's not kid ourselves. From HOPWA to Medicaid to HIV. I mean, we are in a very bad position here. Everything relies on that Senate at this point. So I think what you have to do, and I can put the number in chat, you must call your senator and voice your opinion. You cannot remain silent. And I don't know how else we can frame this up, but a lot is going to ride on this, and it is imperative that you call your senators and you can't be silenced. The trans community cannot be silenced, right? These attacks, we have our voice, and don't let the government try to say you can't say DEI, you can't say this. You have a voice and you have a First Amendment right. You call your senator and tell them, you're living with HIV. your life will be terribly impacted if you take away your Medicaid coverage or Medicare coverage. And Jesse, I want to just point out one more thing. Let's not forget, folks, Medicare also provides very important continuing chronic disease management. Medicare's chronic care coordination under Medicare, I think the Advantage plans, they support people living with HIV as they age and develop comorbidities. I think I got it. Like cardiovascular disease or cancer or diabetes. And also, I don't want to end without at least mentioning mental health and home-based care. These services are critical for people living with HIV, many of whom, and we have all been in this position, face isolation or cognitive decline. And these services are only available in many cases under Medicare. So, and especially if you're a person living with HIV in the rural communities, the isolation there can be very damaging. And so this is important stuff when we talk about Medicare and people living with HIV.
Just a quick facilitation. After Cecilia, we have one more speaker. So we want to wrap up the Q&A by 3:15.
Oh, yes, of course. Thank you. Cecilia.
Yeah, I just want to add one more point to this is, like when we decide to go to our legislators to discuss this, make sure that they know that just by cutting the money doesn't mean that we're getting fewer sick people. What it means is people will get sicker and that would actually eventually, put a even heavier burden, on healthcare. So it's a really bad and very vicious cycle that we need to avoid.
And we have one additional comment that came from the viewers today, and that is if Medicare and Medicaid and Ryan White are shrunk, are there state or local resources that people aging with HIV should be accessing that could either replace or supplement the care that they might have received from those programs? Joey, you and Melanie are experts at community level. Any suggestions for us? No?
Jesse, I know it wasn't asked, and I knew we had the panel there. But on that one, when I think about the administration of community living that funds and works and manages those AAAs, area agencies on aging, even going to them, trying to make inroads and collaborations between the folks aging with HIV and the AAA programs, it's going to be complicated now because, again, their funding as well is being affected. And so I didn't mean to jump in front of y'all, I just took advantage of the pause, that's all.
Yep. Well, it's an open question. Thank you.
I think, Jesse, this is Joe here. I think that it's really important that we start looking at partnerships, both of local and state governments, community organizations that get private funding from foundations, and philanthropists. I think that and obviously that takes lobbying the government to get involved. In the city of San Juan, for example, the mayor is very committed to the community of people living with HIV, and so he's looking at ways in which he can do a positive impact in the possibility of losing funding for the city to treat AIDS and HIV. So he's doing his part, and obviously because he's very committed. But if he wasn't, we would have to go to him and ask him to do so. So he presented that there was a surplus in budget for the municipality on his budget message, which was last week. And so we know that he's doing what he needs to do to mitigate whatever loss we might have.
Thank you for that, Joey. Well, this Q&A session has been exciting, and I know we have one more speaker to wrap things up for us. So Moises, back to you and to the NMAC team and our final speaker.
Thank you. This was another excellent panel and very powerful. So this forum is a call of action. And, you have heard through the presentations and the comments from the panelists that it's so important to mobilize, to organize, to lobbying, to call the Congress, to mobilize new funding with philanthropists, to mobilize the media, to mobilize the community of people living with HIV. So we must re-engage in advocacy at all levels, local, state, and federal levels, to make sure we protect the healthcare infrastructure that we help to develop, that supports the long-term survivors of ourselves and our peers. The fight to end the HIV epidemic is not going to be, it's not over until it's over for everyone, and neither are we, right? So we have a large community of people aging with HIV that are looking into the 70s and 80s. So we need to make sure we protect this legacy of ours. So we have a very special person who will give us the motivation to move forward and get to work. Our inspirational speaker today, a wonderful Yolanda Ross, Dr. Yolanda Ross. Yolanda is a licensed clinical social worker supervisor and a licensed chemical dependency counsel for more than 11 years of experience of clinical and addiction counseling. She is a woman in long-term recovery and is also a woman who is thriving and living strong with HIV for over 18 years. Ms. Ross has a Bachelor of Social Work from the University of Clear Lake and a Master of Social Work from the University of Houston. She also has a second master's degree in health administration and from the University of Houston's Square Clear, and is currently working at Harris County Public Health. She is in the process of achieving her doctorate in social work. Yolanda, is very impressive. I'm so happy that you took the time to speak with us. Ms. Ross is committed to promoting positive changes in the micro and meso and micro levels, and also the society regarding women struggling with substance use and living with HIV. So with all of that, I leave you with Dr. Yolanda Ross.
I gotta change that, y'all, because I did. That's an old introduction. Thank you, Moise. I do have my doctorate in social work. I graduated May 3rd, 2024, and I've been living and thriving with HIV for over 19 years, and I've been clean and sober for over 19 years. So thank you for this amazing opportunity. This discussion has been very motivating for me, because when I was diagnosed on January 25th, 2005, I was in the midst of my addiction. And didn't know anything about HIV care or anything like that, because I was so engrossed in my addiction. When I did achieve sobriety September 12th, 2005, I immediately, at that time, by the grace of God, I was receiving Social Security benefits, my SSI and SSDI. So I had opportunity to get Medicare and Medicaid, and I got linked with HIV doctor here in Houston, Texas. At first, I started out at Thomas Street Clinic, and then I moved into Dr. Joseph Gatz Clinic, in which I was put on medications that really helped me thrive with this disease and become undetectable. And I was also linked to other resources in the form of the Ryan White Care, in which I was able to get free dental work. And I really needed that, because when I was in the midst of my addiction, I did a lot of damage to my teeth. So there was a lot of opportunities that I received under the Ryan White and under Medicare and Medicaid. Mind you, this is 2005, right? And as you can see, it was under different administrations, right? In 2005, it was Bush, and then it was Obama. And then around the time when Trump came into office in 2016, I was gainfully employed. And so, I lost my Medicare and Medicaid because my income increased and all, and then I lost the Ryan White because of my income. But prior to Trump getting into office, those resources was greatly benefited my life. I was able to get healthy. I was able to learn a lot about living with this disease. I was able to, when I came into this beautiful, I like to call a family, in which I learned about getting on the council and learning about Positive Women Network and learning about NMAC, and so many wonderful opportunities came about because of me with my diagnosis and all, but being on Medicare, Medicaid, and Ryan White. As I was listening to this amazing panel, my heart is breaking because, HOPWA is going away. And it is true that we're going to see a lot of individuals in our community end up, homeless. I was just listening to um, a webinar that was saying about the highest levels of HIV rates, and it's occurring in Georgia, North Carolina, Nevada, Louisiana, and Mississippi, Texas. And, with all of these HIV cuts that are affecting our community, I just see us going back in the early 80s when nothing was being done. And that scares me. From a social work perspective, from a woman living with HIV, that scares me. And and one of the things that we've been doing here in Houston and all with Positive Women's Network is that we've been raising our voices and sending, going to the Capitol and writing our senators and our representatives to try to, to address this big, beautiful bill, which is crap, in my opinion, right? Um, One of the things that I am an advocate for is women. I have, because I'm a woman and everything, but one of the populations that's going to be really significantly impacted by these cuts are women who are pregnant and HIV. And we're seeing that in other countries. I'm reading the reports. I'm seeing the reports, and it's just devastating. And what makes me sad is that these lawmakers, they don't get it. They don't understand it. Right? It's all about money, 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 and they're not understanding that these cuts and what it's going to do with our community, if that makes sense. We got a lot to do on the micro, meso, and macro levels of society. We got a lot to do. I have to have faith that our voices will be heard. I have to have faith that the senators would excuse my language, grow some balls and stand up to this big, beautiful bill and do something, I just have to have faith that if we continue to work, that we can continue to make some significant changes. But I know for me, one of the things that I am doing is that I am continuing to work with the population of women that are struggling with a substance use disorder, that may be newly diagnosed, and giving them the resources that they need, treating my clients with dignity and respect, and just being a voice for those who are voiceless. Those are some of the things that I have done in my 19 years of me achieving my sobriety and being an HIV warrior, centering myself around individuals like Stephen Vargas and the Positive Women's Network in Greater Houston, being around women that uplift me and help me as I journey to continue to address these issues in today's society. My biggest fear again is that we're going to fall back because history has a way of repeating itself. I used to hear that from the old people, and I was like, what are they talking about? And then again, just listen to these panelists. It sounds like to me that history is trying to repeat itself, but I have to believe that we have the voices we have the community to stand up against the powers that may be. So with that being said, that's all I have to say. And I'm reading the comments and I'm saying thank you so very much. Again, as you can see, I'm very animated. I'm very passionate about this. It's because, again, we have the power, y'all. We just got to stick together and do and continue on this journey. And thank you for allowing me to share.
Wonderful, Yolanda. You make me emotional a little bit. It's just
Thank
so
you.
beautiful to see you thrive and overcoming challenges and be here
Yes.
with us, sharing your story and motivating us to move forward. Community is everything. Community is everything to me. I think I'm alive because of community. And the message here is that we have the power, we have the resiliency, we have the expertise, we have the drive, and we have the community. So thank you so much for your beautiful and wonderful, powerful
Thank you.
words. And I
Thank
think
you.
with this, we close this great forum. I'm very grateful to everybody that participated. It has been a very rich and very powerful discussion. Thank you to the facilitators and the panelists and all of those that pose questions. And until the next one, have a great weekend coming up tomorrow. All right? Take care, everybody.
Thank you. Y'all have a great weekend. Great job, Yolanda. Mwah.
Yes, thank you, everyone.
Thank you, Stephen. Love you. Bye.
And congratulations,
Thank
Jesse.
you, everyone.
Thanks,
Beautiful,
everybody.
Beautiful, beautiful. Thank you. Thank you.
Thank you. It was amazing.
Thank you, Carlos.